Good evening, everyone, and welcome to the first talk organized by the IISc iGEM team for 2023. I am Shloak Vatsal, and today we are honored to have Dr. M. Kamath Ammembal, MD, DTO, DNB, MRCOG, and a member of the Royal College of Obstetricians and Gynaecologists to talk about endometriosis, the disease we are targeting as this year's project. Sir, there's a lot of unawareness about endometriosis, even in the society today. Could you explain what endometriosis is?
Yes, my friends, it's an absolute pleasure to be here. It's an honor to be part of your, shall we say, adventure. And can I know your name, please?
My name is Shloak Vatsal, sir.
Shloak. Okay. I know that things are pretty informal in the institute, so you need not address me as sir.
Sure.
Okay, it'll be nice. You could call me Dr. Ammembal if that makes you more comfortable.
Sure.
Okay, or anything else, but it doesn't matter. Okay, because I really want to have a conversation on what one would call a very, what actually is a very important and a very, shall we say, devastating disease that is affecting the modern woman. And strangely, it's not understood. It's not talked about. And if you probably do a snap survey of, shall we say, the scientists, or you go to any industry or anywhere, nobody would know about this. But yet, you will see that it's a silent epidemic. And it's affecting, shall we say, a very important cohort of the population, which is the young woman. You can easily say 21st century should belong to women, because they have always been, you know, shall we say, they have always been relegated to the backseat. But their day has come. So we should address problems that affect women, and it should be at the heart of what we do. So that's the sort of idea behind this conversation. I want all of you, Shloak, as well as all others, to feel free to stop me if that's acceptable to your system, and ask questions, and don't spare any effort in trying to understand this, because you may actually find an answer for this. The very fact that we're having this conversation indicates that this is a disease yet to be sorted out, shall we say. Okay, so I'll start off with what is endometriosis. So I'll share the screen. Let me know if it's working.
Yes, your screen is working, sir.
Excellent. So endometriosis is endometrial-like tissue. So I'll just for the moment, I think it may be easier. Can you see me on the screen as well? Because I'm not that familiar with this technology. I'm used to Zoom. Okay.
Yes, sir, you are visible too.
Yeah. Now, I'd rather stop sharing and you look at this particular model. Can you see the model?
Yes.
Okay. This is a model of a uterus. And this is the lining of the uterus. The lining of the uterus is called endometrium. And there are two ovaries and two fallopian tubes on the side. We must remember that this is just not an organ, but it is an industry. It's a very dynamic, exciting place. A place where all of us came from. Put it in simple terms. Okay. So if you look at the lining, every month during the menstrual cycle, as the egg develops, do you have a biology background? I suppose there are many people without biology background here. So just for their benefit, the egg grows, the follicle grows, and estrogen is produced. Estrogen builds the lining of the uterus up. After the release of the follicle, after the release of the egg, pardon me, the same ovary produces a hormone called progesterone, which it sort of stabilizes the endometrium. And at the end of that cycle, when there's been no pregnancy, whatever is built up comes out as menstrual blood. Now this lining is called endometrium. In an ideal world, this endometrium should be in the container, which is the uterus. Now, if it finds itself outside the uterus, as in the tubes, fallopian tubes, on the ovaries, and the greater pelvis. This is the model of a pelvis. Can you see that? You can see the bladder, the uterus, and the rectum. Now, unfortunately, this disease spreads. It's not a tumor. It's not a mass. It's not a lump. It spreads, somewhat like a termite. Spreads all over, outside the pelvis, into the nerves, into the rectum, and it could start infiltrating into the kidneys, into the tubes. These are called ureters. So you can quite clearly see it is a devastating process. So I'll go back to the slides. So as I explained, you have to understand endometriosis from 4 perspectives. The perspective of the disease process, the patient's perspective, the clinician's perspective, and most importantly, from today's meeting, it's the scientist's perspective. As I mentioned here, see how the disease process is spreading to the rectum, behind the uterus, and so on. This slide indicates how the disease progresses gradually from what one would call stage 1 to stage 4. Stage 1 is mild, where there are only few spots of endometriosis. Whereas in stage 4, the whole pelvis is frozen. The bowels, the intestines, the ureters, everything get plastered with the disease process and fibrosis. This is how the uterus and the tube should ideally look like, along with the ovaries in a normal woman. But this is how it's going to look. Are you able to see the slides?
Yes, sir.
Okay, great. So this would be probably, I know you were about to ask me, actually I have shared some questions earlier, and you would be asking this question: what's the magnitude of the problem? Now, before I proceed, does anyone have questions about whatever I said? They're free to ask. Or can I continue? Do you have any questions?
Sure, sir. I think you should continue.
Okay. So you'll be surprised that one in 10 women are affected with this. So if you take any 10 women in an institute, for instance, one would have had endometriosis. And in fact, my suspicion, and even the Royal College says that it could be far more, that's nearly double. That means 1 in 5 women are probably affected by endometriosis. And it's a big reason for severe pelvic pain and, most importantly, infertility. Typically, the patient comes in the young age group, 25 to 30, and often 25 to 40. Many of them are yet to bear children. It mostly affects women who are not yet pregnant and who may have delayed fertility. And it is a major cause of infertility, reduced ovarian reserve. That's the ability of the ovaries to produce eggs. And multiple surgeries. These women, you end up with multiple surgeries, which cause a lot of extensive damage to tissues. And even after all this, for instance, if a woman who has suffered from endometriosis goes for IVF, in vitro fertilization, her success rate for conception is a lot less compared to a woman without endometriosis. And most importantly, there is a personal impact. These women suffer silently, often branded as attention seekers, eventually have low self-esteem. And I have personally encountered women who said they were contemplating self-harm because of the severity of the symptoms and the pelvic pain. So you are obviously looking at an extremely severe disease, which is insidious, underestimated grossly. So any questions at this stage? I hope you're getting a magnitude of the problem, and I hope I'm motivating the young scientists to look at this problem with a new light. Obviously, the treatment has not been effective. I am coming to the treatment at a later stage, but I assume sort of you're getting a sense of how complex this problem is and how prevalent. Because if you go to any apartment building, you'll find at least 2 to 3 women with endometriosis. And these are often young professionals, doctors, scientists, engineers, who would have postponed their pregnancies. Because there is some suspicion that women who delay their conception probably are at a higher risk. This is, of course, considered a little controversial, because would it mean that women have to plan their pregnancies very early just to avoid endometriosis? That's not possible in 21st century. It's not acceptable to say women should try and get pregnant as soon as, by 18 or 19 years or 20 years, just to avoid endometriosis. That defies logic. That defies human values as we see it. Are you following? I hope you're getting a sense of the sort of the challenges that we face because of this disease. Yes. So can I carry on with the presentation, or do you have any queries?
Sure, sir. I think you should carry on.
I can carry on. So let's look at the symptoms. How do these patients, what do they actually have? Yeah. So first of all, you must understand that 1 in 5 patients with endometriosis may not have symptoms at all. I have met, it's not uncommon in our clinic to find patients who have stage 4 endometriosis, which is pretty advanced, and actually have hardly any symptoms. But the common symptoms are heavy and painful menstruation and progressively severe pelvic pain, which can actually be present throughout the menstrual cycle, need not be during menses. Severe pain during sexual intercourse and infertility. Most of these women, a significant portion of these women cannot conceive naturally. And when the disease is severe, as I've shown you in the previous slides, the disease infiltrates into the bowels, into the rectum. And there's severe pain when the woman opens bowels, particularly during menses. And when it involves the ureters, as I've shown you, the tubes that lead down from the kidneys, it can cause severe damage to kidneys. And there can be bleeding from rectum and bladder. And worryingly, endometriosis can spread to lungs and even brain. So there have been reports where women have convulsions during menses because there is bleeding in the brain, in the menstrual tissue, which is in the brain. And there is blood, there is coughing of blood every month during menses because there is abnormal endometrial tissue in the lungs. And this tissue continues to infiltrate, damage and bleed. So what are the conventional therapies? So why do we feel endometriosis is not treated effectively. Treatment can be broadly classified as medical, which is not surgical, and surgical. My specialty is surgical treatment. I am a laparoscopic surgeon. My focus is mainly on radical treatment of endometriosis. Medical therapies are now at present, they're hormone based. That means, as I have described in the past, endometriosis is dependent to some extent on hormone. This may be a sort of incomplete understanding of the disease process, but at least at present, whatever therapies are there are based on cutting off the hormonal sort of stimulation of endometrial tissue. That's why the treatment is generally ineffective, but because endometriosis is much more than hormone sensitive tissue. It's an inflammatory process. Probably there are immune mechanisms at play. So these aspects have not been explored at all. And that's why women are often given high dose hormones, which have significant adverse effects, even increase the risk of breast cancer eventually. And most importantly, hormone therapies interfere with the treatment of infertility. And then comes to the surgery. Now, increasingly, we are getting radical. Radical surgery is where we do extensive excision and removal of tissue from rectum, from ureters, and from the ovaries. Obviously, this leads to very high risk of damage to all the internal organs. And many of these women require more than one surgery. And often I have had the misfortune myself having to do removal of the uterus and ovaries at as young age as 32 or 33 years. So you're looking at an extremely, it is like, how do you describe it? You're caught between the rock and the hard sea. At this stage, I hope you're getting, just to summarize what we have understood, that endometriosis is a severely underestimated disease. It is affecting a very important cohort of the population, the young women of 21st century. It is having devastating impact when it's severe. And the treatment is mainly hormone-based or radical surgery, both of which can cause significant damage and are often, in the best of circumstances, partially effective. That's the context for discussing this disease with the science. So I hope you're getting a sense of what it's like.
Yes.
Yes. Yeah. So I'll continue. Yeah.
Sure.
So what are the challenges faced by the clinician, that is ourselves? We find challenges at multiple levels. It's very difficult to diagnose this disease unless we have done laparoscopy. Like laparoscopy is keyhole surgery where we look inside the peritoneal abdomen and actually look at it directly. As I've shown you some slides. And for ultrasound diagnosis, it requires considerable expertise. So a general radiologist, the general reports that they generally completely miss endometriosis. And then we come to the challenges of treatment and also, even if we manage to remove the disease, it comes back with vengeance in more than half the patients within a couple of years. Symptoms are not specific. As I said, imaging is not very successful, and laparoscopy is what we call the gold standard. That means the absolute way of knowing that one is endometriosis is by laparoscopy, where you directly look at the disease process. Finally, we come to why is research? Now, why is research underfunded? If you look at, say, journal Nature, or if you look at the latest information on this, you'll find that endometriosis research is underfunded for the reasons I've already sort of explained. Because women's health has not been prioritized till now. It is not considered priority by the policymakers and by the public at large. And there is lack of awareness among scientific community, because I think one of the reasons is I find that scientists are more enamored about something like cancer, because for them it is obviously the most devastating illness. The problem is endometriosis behaves somewhat like cancer, but it doesn't kill. As a result, it is underestimated, it is underreported, and generally not prioritized. But at the same time, it's an emerging disease. So because of there is an explosion about awareness about endometriosis, also because of advancement in technology, because we are doing laparoscopy every day now for endometriosis. The awareness about the extent and the severity of the illness is becoming exponentially, it's rising exponentially. So finally coming to how can science really help? How can you guys help? First, we need help in understanding the genetic and immunological basis. Till now, we always thought it's hormones. But reality is probably there is a much deeper reason why. Only see, if you look at it this way, only 10% of women or 20% of women are affected. That means out of 5, only 1 is affected. Though all others are also exposed to similar situation. And we need non-hormonal, non-surgical therapies. We need to be able to identify women at a much earlier stage of endometriosis and to, start the sort of preventive strategies. And if we have done surgical excision, we want to reduce the recurrence rates. And we also want therapies which not only not interfere with treatment for fertility, we want treatments which actually enhance fertility. So finally, I'm coming almost to the end of the presentation. I'd like to just see if anybody has any questions. And then I'll come to the last part, which is what would be an ideal therapy? What would be a magic bullet? Yes, you were about to ask me something.
As you mentioned, sir, that there are some misconceptions around this disease, like the women are considered to be attention seekers. So how does it affect the life of those women overall? Have you seen any such cases where it becomes too much for them to handle or something?
That's usually the case, in fact. There seems to be no light at the end of the tunnel for these women. Typically, they get diagnosed with endometriosis when they are, say, 20 or 25 or 28. And now, once the disease has gone severe, their marital life is affected. They are unable to have sexual intercourse. They are unable to conceive. Their menstrual cycles become hell. And they are not able to concentrate on their work. Like in a month, you have 30 days. The 10 days are knocked off because of endometriosis. Imagine a healthcare professional. Imagine a surgeon who is a woman surgeon. Imagine a woman professor or a woman teacher, a woman banker, a woman industrialist. Imagine if 10 days out of your 30 days are knocked off because of severe pain, heavy bleeding, and pelvic pain. Because you are a man, I'm a man. For us, we have all 30 days in hand. Think about it. Yeah, these women, that is 1 out of 5 women. Let's put it this way. 1 out of 5 women can have this, and out of these, at least 10 to 20% of severe form of the disease. That means if you do the math, out of 100 women in our age group, the young, no, you are not your age group, I'm old. I'm talking about the young lot. Okay. If you do the math, you have 100 women, at least 10 of them will have endometriosis. Probably 20. So 10, let's put it at 10 to 15. Of these 10, at least 3 to 4 will have severe disease. That means out of 100 women, 3 to 4 cannot function normally. And these women are not old pensioners. These women are at the very heart of progress of this country, of the society in general. And there is no light at the end of the tunnel. There is no magic bullet. See. So they keep going to the doctors, they keep taking hormonal medication, then finally they get fed up, then they have massive surgery, doesn't work out. After 1 year, they get the whole thing comes back again, they go have a second surgery, then third surgery. At some stage, something gets damaged, the rectum gets damaged, the fecal matter enters the peritoneum, they lose their life. Or it infiltrates ureters. During surgery, there is damage to the ureters. As I've told you, ureters are these. Okay. Now, what happens if you damage the ureters? The urine starts spilling into the abdomen. And it starts coming out of the uterus. Or, you know, the urine starts causing havoc inside. Imagine having urine flowing into your abdomen every moment of the day. That person cannot be, it is a critical situation. Yeah. So what's the ideal therapy? I hope I've answered your question. I'm sorry, I get a little animated about this issue because I have seen this disease quite a bit. So I hope I have answered your question.
Yes.
Yes. So I'll come to the last sort of what's the ideal therapy? Okay. So if you're looking for a solution beyond what we are doing, what I keep saying is what we are doing is really a band-aid solution. What we need really is a solution that reduces or eliminates the infiltrative disease. That means this disease is not just a tumor, it infiltrates, behaves like cancer. It infiltrates into the tissues. In fact, it's a microscopic disease that causes extensive inflammation and fibrosis. So what we need is something that prevents and reverses inflammation and facilitates fertility. And if we have done surgery, we don't want the disease to come back. So we want a solution which we can incorporate to prevent recurrence. We don't have that still. And of course, any disease, any intervention should have acceptable. We can't say it can't have adverse effects, but it should have an acceptable adverse effect range, a sort of profile. It should not promote malignancy in reproductive organs. You must know that extensive hormonal therapy could expose the woman to cancer of the reproductive organs, particularly the breast. Alternatively, many of the therapies we have now cause what we call iatrogenic menopause, which means we end up causing complete damage of the ovaries or removal of the ovaries. As a result, a woman may have menopause as early as 20, 25 or 30 years of age. And we want a solution which is cost effective, something that is affordable to the masses and convenient to administer. I mean, I would rather not have something that needs to be administered intravenous every now and then. I want something that can be administered locally, perhaps by a device inside the uterus. That is my idea of what one would call ideal therapy.
Sure, so we'll try to administer as many of them as possible in our solution during this project.
Thank you.
We have an audience question from Arpan. He's asking, How does the endometrial tissue reach lungs or brain, as you mentioned some time back?
It's an excellent question. I thank the person for that question. We don't know. It's a surprise. Why would endometrial tissue reach lungs? It's been found on liver. I have seen it when we do laparoscopy. Sometimes we find endometrial tissue on the diaphragm. There have been patients who had to have excision of diaphragmatic tissue. Diaphragm is for those who may not be familiar with that, diaphragm is the muscle between the chest wall and the abdomen and in the brain. So that brings us the question, because can you see this model? Now, what we originally thought was happening was that the menstrual tissue spills into the pelvis through the fallopian tubes, and that gets implanted. That's what we thought was happening. But now we have started rethinking this particular aspect, because obviously the menstrual tissue spilling into the abdomen probably is happening in almost all women. But why is only 1 out of 5 affected? That means these women must have something else. They may have a genetic predisposition. There may be an autoimmune mechanism at play. Something to do with your world, which is the world of biology, the world of molecular biology, world of genetics. If we can crack that code, we may be able to answer that question, and importantly, we may be able to finally find a permanent solution. Something like I was reading about today, I was reading about a vaccine for pancreatic cancer, which has been found to be fairly effective. It's reported in New York Times. We may be able to have some vaccine for this. We may be able to give vaccine to young girls to prevent endometriosis. So we don't know. In a nutshell, I don't know the answer, but that's a very good question.
We have another question from Mayank. He asks, how bad a financial burden does this disease place on a person?
Absolutely devastating. Let me put it this way. First of all, multiple consultations with the doctors. Multiple times they'll have to hop from one unit to another, because most of the units are not specialized in endometriosis, or they simply can't give you the solution. So the patient gets disappointed, moves on to another doctor. So many of them come with huge folders. So if you calculate the consultation fees, the ultrasound scans, these patients have multiple scans. And often the surgical treatment, each surgery could cost anywhere between 2 to 3 lakhs per surgery. And many of these patients require multiple surgeries. And IVF, that is in vitro fertilization, could cost 3 lakhs. And at the end of this process, the sad part is, at the end of this process, they still continue to have endometriosis. So you could look, the burden, the financial burden of endometriosis is not only it's massive, it becomes pointless at some stage for many women. And eventually these women end up having a hysterectomy, which is removal of the uterus and ovaries at very young age. And suddenly they're in the zone of, old age, menopause, when they're 35 years. Imagine, let's imagine, say, a pilot, a captain. Okay, a woman captain flying up, in the airlines. She's not able to get pregnant. She has a career to look after. Okay, now these are classically the women who have the worst endometriosis, because they would have put off their pregnancies. Now, let's suppose this endometriosis causes a devastating effect on her day-to-day life. She is not able to fly planes when she has severe pelvic pain, when she has menstrual bleeding with a lot of pelvic pain. And eventually, at the end of this process, she may end up having a hysterectomy and removal of ovaries. Now, suddenly, she has no hormonal support. She has no estrogenic support. When a woman has no estrogenic support, they can't operate normally, or at least find it very difficult. Especially, sort of professions which require tremendous shall we say, abilities. This is a classic example. The cost is not just in terms of consultation fees or ultrasound or surgeries. It is loss of livelihood. It is loss of, lack of professional progress, career progress.
There's another question, sir, from Swaraj. He has asked, given the knowledge of relative difficulty in diagnosing, what are the possible techniques to diagnose the disease, and what's an approximate rate of success in the diagnosis?
Yeah, again, excellent question. About, the time lag between onset of symptoms to formal diagnosis, according to European Society of Human Reproduction, is 7 years. Imagine. That means this patient starts complaining of problems, goes around multiple consultations, can take up to 7 years before somebody diagnoses endometriosis. And this is in developed countries. That just tells you how ineffective the present diagnostic tools are. First of all, it requires high skill in ultrasound to be able to identify certain features of endometriosis, because unlike, let us say, a tumor, let us say a fibroid is a lump in the uterus. It's pretty easy to diagnose by a regular sonologist. But endometriosis requires high specialization because you should be able to see tissues which are very subtle. It's very difficult to identify that by imaging. What about blood tests? What about blood tests like, say, CA-125, which is a common blood test which is requested for ovarian cancer? It is a marker for endometriosis as well. But because it is non-specific, it can be raised in any condition. It can be raised just because the woman has menses. It can be raised if there are other inflammatory conditions. So we really don't have a good laboratory, highly specific laboratory marker for endometriosis. So that would be another area where scientists can help, is to identify highly specific marker where, for example, we are able to do the blood test and maybe combine with the ultrasound scan and say with great certainty that this patient has endometriosis, we could be able to initiate therapy without the need for laparoscopy and prevent disease from progressing from stage 1 to stage 4. That's an excellent question.
Yes, I think the direction which you have showed might be something that our future teams might want to work upon.
Yes.
There's another question from Abhishek.
Yes.
He wants to ask, are women with PCOS more susceptible to endometriosis?
No. Because polycystic ovarian syndrome is actually a totally different category. It is a classic hormonal imbalance, whereas endometriosis is actual pathology. You understand the difference? Polycystic ovarian syndrome is an alteration in the hormonal profile, whereas endometriosis is actual pathological disease process that is spreading into the pelvis. You see the distinction. And polycystic ovarian syndrome women present totally differently. They present with hormonal, sort of classic hormonal appearance. That's where the paradox is. Now, in endometriosis, the problem is, the question is actually quite interesting and it's quite good, because The problem is, even as gynecologists, we tend to put both somewhat together in this, neighboring compartments. They are not. Endometriosis actually is a very aggressive, infiltrating, damaging disease. Polycystic ovarian syndrome doesn't damage like endometriosis. It causes problems related to, say, getting pregnant because they're not able to release eggs regularly. But it doesn't cause damage to the tissues. Are you seeing the difference? Yeah. I'm happy for the questions. I'm grateful. That means I'm getting at least some, I'm getting across, and we are able to actually create a picture of what the problem is in the minds of young scientists. It's a delight.
So there's another question from Aman. He wants to ask about the previous question that Swaraj asked. What stage has endometriosis usually reached by the time formal diagnosis occurs usually?
Again, I'm grateful for these questions because these questions actually indicate that our conversation has been effective. That's the problem, because you can imagine if the gap on average between symptoms and diagnosis is 7 years, you can sort of imagine that a significant, I can't give you numbers, but a significant proportion in our practice, most of the patients who come are stage 4 endometriosis. That's because probably they are coming purely for surgery. So I can't speak from our own, clinic perspective, but I can tell you that it's not uncommon. If you really do a study, probably you'll not be surprised to find that most of the patients who present significant portion, probably more than 50–60% present in stage 3 to 4, simply because the diagnosis is so difficult. It is underestimated even by gynecologists. And often the treatment, what happens is the surgical therapy is so difficult, so complex, so damaging that many of the doctors simply want to avoid surgery because it carries significant risk to the physician who is going to operate. Obviously, if you're going to, if there's a high risk of damage to the rectum, to the ureters, there is medical legal implication. Correct? So you could end up getting blamed medical legally for the complications. So as a result, there is reluctance to take on such cases. So what happens is many of these women receive hormonal therapies, aggressive hormonal therapies, which are ineffective, and the disease continues to progress. That's we want scientists to help us to break that cycle, where we are able to, first of all, identify at-risk women, pick them at that early, and prevent it from progressing from stage 1 to stage 4. But like your friend was asking just now, a significant portion end up with stage 4.
Building on this, there's another question. Are the stages of endometriosis, as you mentioned, similar to the stages of cancer that we see?
Excellent question again. Thank you for that. Yes, sadly, yes. They sound pretty similar. Its only difference is endometriosis is locally invasive. It's usually confined to this. And in some ways, it doesn't behave like cancer, because what happens in cancer is it starts invading and multiplying aggressively. This just invades, causes inflammation and fibrosis. It doesn't multiply like cancerous cells. You see the distinction. So when cells multiply aggressively, they soak up the nutrition, they soak up and they cause extensive damage to vital organs. This too can, but this is local. It is confined mostly to this area. But your question, the person who asked the question is actually asking a very good question, because when we say stages, when we counsel patients, when we tell them, when I showed the same slides, some of the slides to educate my patients here, they ask the same question: is it like cancer, like stage 1, stage? Unfortunately, yes. And yet, paradoxically, underestimated.
Actually, we have one more question.
Yes, of course.
So seeing it has been asked by Akshata, seeing as endometriosis is becoming more and more prevalent, and as most treatment modalities, even ones being developed, have side effects, why isn't it feasible idea to nip endometriosis in the bud by encouraging screening of endometriosis? Is there anything that would be a setback to this preventive method?
Yes, the problem is endometriosis is very insidious. It starts off with tiny little, sort of disease, very small little nodules and implants. As a result, it's difficult to pick it up. But if we are able to have a specific marker for endometriosis in a woman who comes with mildest of symptoms, and we are able to nail endometriosis with a reasonable certainty by simple blood tests, simple screening tools, then it's possible. Screening is extremely hard prospect, but it is doable. See, if 1 in 10 women are affected, let's look at it this way. If that means 10% at least are affected, probably 20% according to Royal College. Your chance of picking endometriosis is very high because there is high prevalence in the population. You're not looking for a very rare disease in a big population. You understand the difference. Let's talk about a disease X, which is prevalence is 1 in say 10,000 or 1 in 1,000. It's very difficult to screen, but commonly prevalent, relatively easy. Strangely, we don't have a screening tool. That's because, again, lack of funding, lack of awareness amongst the public and the population scientists leads to lack of progress on screening tools. We need screening tools so that we are able to break the cycle, the progression of the disease from stage 1 to stage 4.
Aman is asking on building upon the last question that you answered. What are the conditions that are similar to endometriosis that can also be considered as endometriosis, but they are not actually?
Again, thanks, Aman, for this fantastic question. Can you see the uterus? Yeah. Now, I said that endometriosis is where the disease process spills out of the uterus into the pelvis. Now, what if this disease process, instead of spilling out, enters the muscle of the uterus? That's not a normal place for endometrial tissue to be, but that's what happens in these women. This condition is called adenomyosis. In fact, I dare say it's more difficult to treat adenomyosis than endometriosis. It's a similar disease, but it is affecting muscle of the uterus. It causes the same symptoms. The problem is, at least with endometriosis, you can do surgical excision. That means you can remove some of the disease. Here, the only way to treat is to remove the uterus itself. Now, how can you remove the uterus in a 25 or 28-year-old woman with adenomyosis? She has not completed a childbearing. You follow me? So can I have the Mirena, please? Yeah. Now, what are we doing to treat adenomyosis? We are using a device called Mirena. I don't know whether if you have heard of Mirena. So that's the device. Okay, this is inserted into the uterus and it comes as a T-shaped structure. This one, can you see it? This one. It releases progesterone into the lining of the uterus and thereby into the muscle of the uterus. Now, same, if you are able to administer whatever you guys are going to finally come, if we are able to deliver this through this device into the uterus, wouldn't that be great? So it would not only help endometriosis, it may actually heal the endometrial tissue which is implanting into the muscle. In other words, adenomyosis. And thereby you have killed two birds with one stone because they're similar diseases. That's what I was talking about. Yeah. What advice I have for the iGEM team and to scientists at large, whoever sees this, is I don't know whether one day we will get a solution which is better than what we have. I really don't know, because I feel hopeless when I look at the disease. We have to be optimistic. But all I can say is, even if you may not get the golden bullet, working on this will open up opportunity to treat a lot of similar diseases. Endometriosis is one of several similar kind of diseases, including endometrial cancer. So that's what I would tell the team, that you work on this. You may not find a solution for endometriosis, but you will start exploring this area and you may find answers for many of the other problems that is dogging women's health in the same range. Okay, thank you.
Thank you, sir. That was quite helpful. Thank you for joining us today. Your expertise and insights have been incredibly valuable, and we'll surely try to work on as many pointers as you have given. And on the behalf of IISc iGEM team, I would like to express my sincere gratitude to everyone who has been a part of this talk. The presence and participation has made this talk a success. We started it with this great beginning, and we hope to do best in the coming times. Thank you.
Thank you. Bye.
Thank you.